In this segment, we're going to demonstrate counterstrain technique for the lower anterior thoracic tender points AT9, AT10, AT11, and then on another segment we'll demonstrate AT12. So again, in review, the anterior thoracic tender point AT9 was 3/4 of the way from the tip of the xiphoid to the umbilicus, and typically these points are not pure midline, but they usually lateralize to one side or the other in this mid and subsequent lower rectus abdominis muscle. The AT10 point is 1/4 the distance from the umbilicus to the pubic symphysis, and the AT11 is going to be halfway between the umbilicus and the pubic symphysis. So if we elicit that tender response from the patient, and we'll say right in here we had a little twitch and the patient said that that was tender and we felt a little tense edematous tissue, we'll tell the patient to remember that tenderness and we're going to call that a 10, and now we're going to find the position where that position of optimal comfort, where we had complete resolution or as close to 100% resolution as possible. We could actually elevate the head of the table to add more flexion for the upper and mid torso. Now we're going to flex the hips and knees passively. We're going to tell our patient to relax, take a nice deep breath, fall asleep, and then we're going to take her into flexion. And we're going to find that best position of flexion where we find the most optimal position of comfort for the patient. As we reprobe and she says it's a 5, we may have to add a little more or less flexion. We feel the softening. We're going to take her knees. Typically the knees and the pelvis are going to rotate toward me or the tender point, which will rotate the torso and the upper of the two segments away from the tender point side. And then we're going to add side bending toward by taking her feet and ankles toward until we feel the complete resolution of the tender point and the patient says it's 0 or as close to 0 as possible. So this, in this case, this AT10 point required flexion, side bending toward, and the knees and pelvis toward, which rotates the torso away. We hold for 90 seconds. Again, every 30 seconds or so we can reprobe to make sure we're still at 0. After the 90 seconds is up, we tell our patient to relax. We position her slowly back to the midline, and then relax the feet. We take her a little bit into flexion so she can relax, and then let her feet just kind of drop down. Good. So there's no contraction of any of the hip flexors. Good. And relax. Again, our finger has not left the location, but we were not constantly pressing. We were just only pressing when we wanted to re-quantify the tender point. Now we recheck, and hopefully the patient says the tenderness is completely alleviated or at least 70% resolution of the original tender point.